Thanks for joining our presentation. Philadelphia International Medicine's Global Education Media Program is a monthly digital platform that invites physicians from around the world to exchange knowledge and innovative uses of medical technology, review the latest advancements in research and clinical care, and share best practices in case reviews. To contact our presenter, refer a patient, or more information, email physicians@philadelphiamedicine.com. Follow PIM's YouTube channel for more educational videos.
It's a tremendous honor. Thank you for the opportunity to speak. I certainly wish I was there in person to deliver this talk, but maybe in the future we'll be able to facilitate that and to be able to have face-to-face interaction. The lecture today is on thoracolumbar trauma, something that we very commonly encounter in the Philadelphia area. Rothman Institute, Thomas Jefferson takes care of the vast majority of the spinal trauma in the region, not just in the Philadelphia area, but in the surrounding states. Most of the spinal cord injury and thoracolumbar trauma is transferred in for us to manage, and so we see quite a bit of it. Just to briefly kind of discuss my bibliography, I'm from Pittsburgh, Pennsylvania. I did my medical school and residency at University of Pittsburgh. As Arturo said, I did my fellowship at Thomas Jefferson under the direction of Dr. Alex Vaquero, and I'm currently a spinal surgeon at the Rothman Institute. My practice is predominantly adult degenerative surgery. However, I do the full gamut of deformity, degenerative conditions, and I certainly take care of a lot of trauma. I am located in Atlantic City, so I live maybe about an hour from Philadelphia, and there is a major level 1 trauma center in Atlantic City in which I take care of all the spinal trauma. So today we're going to kind of briefly discuss some of the classification systems that we use to define thoracolumbar trauma. I think when you look at any classification system, you have to kind of understand the pitfalls of the classification systems, kind of the pros and cons, and what they're really designed in order for us to do, ultimately to help us guide in the management and treatment of these injuries. And then certainly there are a lot of controversies regarding treating thoracolumbar trauma, particularly burst fractures in neurologically intact patients. Also, there's some technical considerations. What's the most appropriate approach to stabilize the spinal column, decompress the neural elements, and also if fusion or non-fusion options are appropriate, and then just show a few cases and open it up to any questions that you may have. Thoracolumbar trauma is very common, accounts for about 90% of all spinal fractures. Burst fractures are about 20% of that in a bimodal distribution. Very important for us to be able to define stability. That's one of the tenets of any spinal trauma, is to be able to assess if a lesion is unstable, which would predispose someone to a worsening neurological injury. Certainly, you have to take into consideration specific patient modifiers, such as ankylosing spondylitis, as that certainly changes the tenor of the injuries. And there's a lot of variations in treatment and approaches, and we will kind of delve into that. So when these patients come in, they're triaged. Initially, it's very important to get a history of physical and try to get a baseline examination. We try to get an ASIA examination on these patients. Very important to be cognizant of patients that are in spinal shock or neurogenic shock when they present. I have seen, when we first started our trauma center, patients with spinal injuries would come in and they would get XLAPs by general surgery because they were hypotensive. And in reality, the patients were just in neurogenic shock and they just needed pressors in order to maintain their blood pressure. So it's important to be cognizant of that phenomenon, which occurs with a lot of these injuries, particularly cord level injuries. These people can present with spinal shock. It's be difficult to really delineate or determine their level of injury. But mechanism is obviously important. The high mechanisms of injury, obviously you have to be suspicious. Again, things like ankylosing spondylitis can be very minimal trauma and yet yield very unstable injuries. So ASIA classification, everyone, this is a pretty standard way for us to be able to identify kind of the level of spinal cord injury, spinal cord involvement. Obviously, that can't be accurately done in the setting of neurogenic shock, and it can be challenging, particularly when these in the polytrauma patients to get accurate examinations, because oftentimes these patients are intubated, they have head trauma or other injuries, which would make obtaining a baseline neurological exam difficult. But it is important to try to do that so you can monitor these patients' progression during and after their operative treatment. So stability is something which is very important for us to be able to define. Any injury which disrupts the stability of the spinal column predisposes patients to further neurological injury. This was defined by Dr. White and Punjabi in the 90s, and that definition was the ability of the spine under physiologic loads to prevent initial or additional neurological damage, pain, or gross deformity. And Dr. White is a legend in the field. I don't know if you guys are familiar with him, but he was the former chairman at Harvard spine surgery and practiced spine surgery for 40 plus years. He's now since retired. So my mentor, Alex Vaquero, he's currently my boss. He's the chairman of Rothman Institute, and he was my fellowship director. He developed this thoracolumbar injury classification system in 2005. And really the advantage of this system that it really built upon the previous classification systems, the Denny classification, Magruder classification, that really were solely based upon injury mechanism and morphological classification. So what this system brought into play was the assessment of the posterior ligamentous complex, which is clearly very important in regards to stability of the spinal column and can influence approach in the way that we treat these injuries, and also patient's neurological assessment initially. Both of those things heavily factor into whether these injuries are treated surgically, non-surgically, and even the approach that should be taken in order to stabilize and decompress these injuries. And so this was composed of really a couple components. Obviously, there's a morphological classification, which is assigned a point system, compression first, burst fracture, injuries that have a translational or rotational component, and then obviously distraction injuries are given the most point value. There's an assessment of the posterior ligamentous complex, and that is, it can be a clinical assessment. It can be based upon any radiographic imaging study to determine if that is disrupted. Surprisingly, studies have shown that there's not high intra-observer reliability when assessing posterior ligamentous complex injuries. It's not something that we universally agree upon as surgeons, but certainly the point is to understand the importance of the structure and for it to be a thought when you're assessing these injury patterns, and then ultimately neurological status. And so these factors in conjunction lead to a score which can dictate treatment. And that was, pretty novel in 2005. Dr. Vaquero got his PhD doing this research, and it's certainly something, that we use a tenet for assessing these injuries. There's deficiencies in this classification system. Things like ankylosing spondylitis aren't really taken into account. If you have overlying open fractures or burns or something which would preclude normal treatment, that has to be taken into consideration. Obviously, patients that have head injuries, you can't assess them. You can't get a neurological status, so they can't be scored by the TLIX system. Or penetrating trauma typically is treated non-operatively, but again, the TLIX classification does not guide management of those type of injury patterns. And one of the big deficiencies with the TLIX classification is kind of assessing the burst fracture in a neurologically intact patient, specifically fractures right at the thoracolumbar junction, which are stable injuries. There may be a TLIX-2 classification, but they're right at the thoracolumbar junction, and there's a predisposition for these to fall into kyphosis. So these injuries, which were initially managed non-operatively, people fall into kyphosis, have intractable pain, sagittal deformities, and then require substantially more surgery than if they were just treated initially. And so this is definitely a deficiency within the TLIX classification, as these injuries in the intact patient are TLIX-2 classification, which would historically be treated non-operatively. So this led to the development of this AO spine injury system. This was also done, Dr. Vaquero was also integral among many other surgeons around the world in developing this AO spine classification. And really the thought was to expand upon the TLIX classification and to kind of address some of the deficiencies in the TLIX classification. Some of the biggest changes were the morphological assessment. So this AO spine injury score further delineates fracture morphologies, particularly in regards to burst fractures. So when you have a burst this further delineates burst fractures from incomplete to complete bursts. So if you have a burst fracture which involves one or both end plates, that's designated the A3 and the A4 classification, and that there's a higher point value denoted to that, which may lead to surgical intervention. It really highlights the importance of the anterior column. If you have a complete burst fracture, even in a neurologically intact patient, that's someone which you may consider surgical intervention due to the concerns of them falling into kyphosis, losing that anterior column stability. And so that's certainly a difference between that and the TLIX classification. Second is the distraction injuries. Because there's poor intra-observer reliability with assessing posterior ligamentous complex injuries, posterior ligamentous complex is kind of bundled into injury morphology. And so when you have patients with tension band disruptions or even hyperextension injuries, the posterior ligamentous complex assessment is based purely on injury morphology, not really the need to assess the integrity of the posterior ligamentous complex itself. The B3 classification is for hyperextension injuries. So those are the ankylosing spondy cases. That's denoted a point value of 7. So that would push you towards surgical intervention. Again, that was a deficiency in the TLIX classification. There was no real way to quantitate those injuries in the previous classification system. This is just kind of reiterating that point that with this new injury classification, it further delineates injury morphology. So it helps us to differentiate between an incomplete and a complete burst. An incomplete burst is given 3 points. A complete burst is given 5 points in this system. Whereas with the TLIX classification, a burst fracture in general will receive 2 points irrespective of the amount of involvement of the end plates. Other differences between this classification system is that there is a designation for a transient neurological deficit. So if you have somebody who had a burst fracture who had transient paresthesias that have since resolved, we can now quantitate that. And a patient that had transient paresthesias would indicate that there was some translation or some neurological compression that has since resolved, but now that can be included in the classification system and may guide or push us towards surgical intervention. There's also they included patients that you couldn't assess their neurological status, such as people who were sedated or have head injuries, which is very common in this trauma population. So in conclusion, in regards to these classification systems, they're similar. The AO spine classification has built upon with the TLIX classification established in 2005. Both provide a summative score, which allow us to assess these injuries and can guide us towards operative treatment. There is also some discussion that these classification systems can lead us towards approach, although that's pretty controversial. And we'll discuss that a little bit more in more detail in future slides. But certainly, a TLIX classification of 5 or above typically is treated operatively. AO spine typically 6 or above is treated operatively. And that includes morphology of the patient, injury classification, assessment of their neurological status, and in the TLIX classification, assessment of the posterior ligamentous complex. So really the controversy with treating these injuries comes for the burst fracture in a neurologically intact patient, right? So if you have, with the TLIX classification and the AO spine injury classification system, if you have a neurologically intact patient, a burst fracture, a pure burst axial load, no disruption of posterior ligamentous complex, no neurological injury, that's a TLIX score of 2. Those traditionally are treated non-operatively. AO spine injury classification, if it's an incomplete A3 or a complete burst, that's a 3 or a 5. So that in and of itself still is a gray area in regards to treating these injuries. If you have a burst fracture that is complete and they have a transient neurological deficit, that will give you a score of 6, which may lead you towards surgical intervention. But certainly there's a gray area in regards to treating these patients. One of the foundational studies in regards to how we manage neurologically intact burst fractures is this study from Kirk Wood from 2003. He's at Stanford now. He was previously at University of Pittsburgh initially and then at Harvard. There are many deficiencies in this study, but this was certainly a foundational study which would indicate that neurologically intact burst fractures are treated non-operatively. And so they looked at 47 patients, operative versus non-operative. And in the short-term follow-up, they didn't find any significant differences in post-treatment kyphosis, pain, or return to work. And there was a subsequent follow-up to this study years later in which they had 37 of the original 47 patients, and actually patients who were treated non-operatively with these neurologically intact thoracolumbar burst fractures did better in this small subset of patients than the patients that were treated surgically. And so this is a foundational study in regards to our philosophy for treating these neurologically intact burst fractures non-operatively. Certainly now there is a lot of literature which would support the fact that neurologically intact bursts should be treated operatively, particularly if it's a complete burst in the thoracolumbar junction. Patients are quicker to mobilize, less pain, and so you can find literature to support either claim, but I think the tenet in the foundation is that most of the time these are treated without surgery. Goals of surgery, we're familiar with: restoration of alignment, attainment of stability, and decompressing the neural elements. And certainly there are a lot of considerations and a lot of ways to achieve these goals. Things that have to be taken into consideration is the nature of the fracture, the location. If it's high in the thoracic spine, may limit your ability to access it anteriorly. Neurological status of the patient. If you have an access surgeon, you have familiarity with the approach, and then obviously medical comorbidities and other modifiers would influence your approach in these patients. A lot of different ways to approach the spine. We don't have to go through every approach, but certainly there are a lot of anterior and posterior approach options. Several posterior approach options which still allow you direct access to the anterior column. Irrespective of how these injuries are approached, there has not been any definitive data which would illustrate that direct decompression influences neurological outcome. And so, you know, the general tenet or the general teaching has always been people who have neurological deficits, particularly incomplete injuries at cord level pathology, incomplete injuries, they get direct decompression. And that is just a foundational principle which we were taught, but there's not really literature. The literature doesn't bear that out. That direct anterior approach substantially influences neurological outcome. And so, you know, when we evaluate these injuries, clearly, first thing we're assessing is patient's neurological status. Do they need a direct or indirect decompression? Still, we typically do lean towards direct decompression, particularly for incomplete injuries that are cord level. Assessment of posterior ligamentous complex. If that's disrupted, you're going to have to recreate that tension band posteriorly with posterior instrumentation. If someone has a disrupted posterior ligamentous complex, and an all anterior approach is typically not performed. And then obviously patient modifiers such as ankylosing spondylitis and those sorts of things come into consideration. Fusion versus not fusion is something which has been discussed more recently. And I think there's probably a lot of geographical variation as to how these things are treated. People who much more aggressively treat burst fractures in the neurologically intact patients typically have a propensity just to drop rods through a percutaneous approach and may not necessarily do fusion. There are not a lot of good studies which would support one over the other. The recent meta-analysis really hasn't bore out any difference between patients who are fused or not fused. Obviously, the theoretical concern with not fusion is hardware failure, and then also the potential need for further surgery to remove instrumentation so it does not break. However, that theoretical concern has not been bore out in the literature. Certainly, there are indications for doing non-fusion techniques in these patients. This was a patient that we saw that had a B2 injury. She had some transient neurological deficit, clearly had disruption of her posterior tension band, and she was a young, healthy woman with good bone stock. She reduced on the table, and so this was a clear indication for a minimally invasive non-fusion technique, which we were able to mobilize this lady without a brace. And certainly there's indication for this approach. And I think that that's a dealer's choice type decision. But particularly in young patients who are healthy with good bone stock, with ligamentous injuries, we occasionally will treat these patients non-fusion through minimally invasive techniques to aid in mobilization. So here are a couple of cases. Illustrate some failures and then kind of our application to the classification system. So this is a case that came into Thomas Jefferson. It was a 46-year-old woman. She was in a motor vehicle accident. She clearly has a burst fracture of L3. This is a complete burst, so you can see a sagittal split through both end plates. There's substantial comminution of the vertebral body. There's a green stick fracture within the lamina, which would indicate potentially a traumatic neurotomy or entrapped nerve roots, which you can see on the left-hand side. She presented with severe radicular leg pain and weakness in her lower extremities. So I think, irrespective, most people would agree that this is an operative case, right? So she has a burst fracture, which is a 2 by the Telix classification. She has radicular symptoms, and she has indeterminate disruption of her posterior ligamentous complex. So this is probably a Telix score 6. Her MRI illustrates, pretty substantial canal compromise, and you can see, the degree of canal compromise on her CT scan. So she was taken in the middle of the night and had this short segment fusion. So I think if you look at this, you can be pretty critical of this approach to treatment in retrospect, considering the fact that she has a complete burst fracture. She has good bone quality, but we did an open fusion, laminectomy and fusion, no anterior column support. She improved neurologically, but this was a pretty predictable failure in that we did not reconstitute the anterior column. And so this A3 or A4 injury on the AO injury severity score classification would denote that maybe this lady, particularly for a short segment fusion, should have had some type of anterior column support. And so she failed about 3 or 4 weeks post-operatively, had to be taken back and revised with a posterior fusion and then a corpectomy through a lateral approach. And ultimately, she did well. This is the classic ankylosing spondylitis case, which we all very frequently see. This is a gentleman who has psoriatic arthritis who fell, hyperextension injury. This was actually missed in the emergency room. The patient was seen and was sent home in a brace. We were never called, and we're a very high, we see a lot of high volume injury center. And so it can show you that these things can happen even in high volume centers. But this was clearly an unstable injury, extension through ankylosing spine at the T9-10 segment, and it was initially missed. The guy represented with an epidural hematoma and incomplete spinal cord injury. So this is a B3 classification, the AO's injuries score. So that's denoted 7 points, and he has an incomplete spinal cord injury. Clearly, this is an operative case. Ankylosing spondylitis cases are typically, for us, treated through a posterior approach. Most of these patients will fuse. This is a bone-forming problem, and so very rarely do we perform any anterior column support for ank-spondy cases. The key is to try to get them reduced, which can be challenging. But he was treated just through our posterior approach, and he healed. And finally, a case which is a little unusual is a penetrating trauma case. So most of the penetrating trauma cases that we see in the thoracolumbar spine are non-operative. This was a rare circumstance in which this young man was shot with a low caliber projectile, and the bullet was actually within his spinal column. He presented with Codd-Aquinas syndrome. You can see his bullet sit in the middle of his spinal column. Clearly, neither one of the injury classification systems are going to be able to account for an injury like this. But you can see that bullet is migrating within his spinal column. And so we took him to surgery, performed a neurotomy, removed the bullet, and he actually had a pretty substantial improvement neurologically. So, when assessing these injuries, it's important to get a history. Mechanism of injury is very important. We try to get Asia classifications on these patients. You have to be cognizant of people that come in neurogenic shock, obviously, because that will affect our ability to assess them neurologically initially. Patients that have core level injuries get A-lines and MAP goals. It's very critical to make sure that we optimize them from a physiological standpoint. In regards to approach in surgical intervention, there never has been any literature which would support one particular approach over another. We have a tendency to do anterior approaches on patients who have incomplete injuries at cord level pathology, except for high in the thoracic or mid-thoracic spine. The morbidity of a thoracotomy sometimes precludes that, and we'll do a costotransversectomy and use an expandable cage. You can get through the anterior column through those type of approaches. We typically do fuse burst fractures, except in young patients with ligamentous injuries, with good bone stock, then those are the indications that we typically will do percutaneous fixation for these injuries. But the neurologically intact burst fracture is certainly controversial. I would say the vast majority of these patients in our practice are still treated non-operatively unless there is substantial anterior column compromise and it's at the thoracolumbar junction. Questions?